overall appearance assessment identifies dysmorphic features that signal genetic syndromes associated with congenital heart disease. Family history proves essential, as siblings with congenital heart disease more than double the likelihood of future children having cardiac defects, while parental history also increases risk. Dysmorphic features provide immediate clues to underlying chromosomal abnormalities or specific genetic syndromes with cardiac associations. Respiratory effort reveals cardiac compromise through specific patterns. Infants with cardiac obstructive physiology demonstrate shallow, rapid respirations with intercostal and suprasternal retractions. Tachypnea with nasal flaring indicates elevated pulmonary venous pressures, while grunting respirations represent a particularly concerning sign accompanying severe heart failure and decreased systemic perfusion. These respiratory changes often precede other obvious cardiac signs. Cyanosis assessment requires understanding physiologic thresholds and distribution patterns. Central cyanosis becomes clinically evident when arterial saturation drops below 80 to 85%, requiring roughly 5 grams of hemoglobin to be desaturated before becoming visible. Central cyanosis suggests right-to-left shunting or severe pulmonary disease, while peripheral cyanosis may indicate poor perfusion. Differential cyanosis patterns provide specific diagnostic clues about ductal-dependent lesions. Activity tolerance and feeding difficulties reflect the infant's cardiovascular reserve. Signs of congestive heart failure include poor feeding, excessive diaphoresis during feeds, tachycardia, and failure to thrive with diminished weight gain. These symptoms often develop as pulmonary vascular resistance decreases and left-to-right shunting increases, creating volume overload. Degree of distress and general perfusion assessment involves multiple parameters, though with recognized limitations. Capillary refill time, while widely used, shows poor correlation with systemic blood flow in very low birth weight neonates, with normal values ranging from 1.6 to 8.8 seconds in healthy newborns. Core peripheral temperature differences and peripheral perfusion assessment provide additional perfusion indicators, though their reliability varies with clinical conditions and ambient factors. Four-extremity blood pressures serve as the cornerstone for coarctation detection, with upper to lower extremity blood pressure differences indicating aortic obstruction. This measurement proves essential for diagnosing coarctation of the aorta, where strong pulses in upper extremities contrasted with weak or absent pulses in lower extremities. Lower extremity pulses create the classic presentation. Normal gestational and postnatal age-dependent blood pressure ranges must be considered, as gestation and postnatal age represent the dominant influences on blood pressure values. Pre- and post-ductal oxygen saturation measurements provide critical diagnostic information for differentiating cardiac from pulmonary disease. Decreased post-ductal oxygen saturations compared to pre-ductal values suggests right-to-left shunting due to increased pulmonary vascular resistance. The unusual pattern where preductal saturation reads lower than postductal occurs specifically when transposition of the great arteries combines with pulmonary hypertension and patent ductus arteriosus, creating reverse differential cyanosis. Heart rate assessment requires continuous monitoring through electrocardiogram, though many factors beyond cardiovascular regulation affect heart rate, limiting its diagnostic specificity for circulatory compromise. Despite this limitation, heart rate monitoring maintains widespread utility in conjunction with other cardiovascular parameters for comprehensive assessment of hemodynamic status. Simultaneous brachial and femoral pulse assessment allows comparison of timing and intensity between upper and lower extremity pulsations. Assessment of femoral and upper extremity pulses proves essential for detecting coarctation, where diminished or absent femoral pulses contrast with normal or strong upper extremity pulses. This technique provides immediate bedside information about potential aortic obstruction. Capillary refill and perfusion assessment carry significant limitations despite widespread clinical use. Studies demonstrate poor correlation between capillary refill time and systemic blood flow in very low birth weight neonates, with normal values ranging from 1.6 to 8.8 seconds in healthy newborns during the first 72 postnatal hours. Although traditionally accepting capillary refill time of 3 seconds or less as normal, actual measurements show 4.23 plus or minus 1.47 seconds as the average in healthy newborns. Measurement site variability occurs between sternum, forehead, hand, and feet locations, and environmental factors including temperature affect reliability. Only when capillary refill time exceeds 5 seconds does it achieve clinically relevant specificity for detecting compromised perfusion. Palpation provides critical diagnostic information that often reveals cardiac pathology before auscultation. The point of maximal impulse normally sits at the fifth intercostal space, mid-clavicular line. In cardiac disease, the PMY shifts. Leftward and downward displacement indicates ventricular enlargement from chronic volume overload, states like large VSDS or severe valvular insufficiency. An overactive hyperdynamic impulse suggests increased stroke volume from left to right shunts or hyperdynamic states, while a sustained heaving quality indicates pressure overload from obstruction. Thrills are palpable vibrations representing grade 4 or higher murmurs with turbulent blood flow velocities. Location correlates with the underlying lesion. Upper left sternal border thrills suggest pulmonary stenosis with gradients exceeding 50 millimeters of mercury, while lower left sternal border thrills indicate VSDS with significant shunting. The intensity of a thrill directly correlates with the pressure gradient across the defect. Peripheral pulse assessment requires systematic evaluation. Simultaneous palpation of right brachial and right femoral pulses detects coarctation, delayed or diminished femoral pulses with upper extremity. Hypertension indicates aortic narrowing. Bounding pulses with wide pulse pressure suggests PDA with diastolic runoff or aortic insufficiency. Weak pulses throughout indicate poor cardiac output from myocardial dysfunction or critical obstruction. Hepatomegaly develops from systemic venous congestion when right atrial pressures exceed 10 to 12 millimeters of mercury. The liver edge extends beyond 2 centimeters below the costal margin in heart failure. Firm, tender hepatomegaly indicates acute congestion from ductal closure in critical left-sided lesions, while chronic congestion produces non-tender enlargement. Document the liver span in centimeters for serial assessment of volume status. Auscultation in the NICU must be systematic and precise, because subtle findings may indicate critical pathology. Start with the 4 standard valve areas: right upper sternal border for aortic, left upper sternal border for pulmonic, left lower sternal border for tricuspid, and the apex for mitral. These sites help localize murmurs and correlate them with underlying structural lesions. Extend listening to additional regions. The left lower sternal border is especially useful for detecting ventricular septal defects or tricuspid pathology. Murmurs that radiate to the back or axilla suggest lesions such as peripheral pulmonic stenosis or patent ductus arteriosus. Beyond the chest, auscultation of the fontanelle and liver is uniquely important in neonates. A continuous bruit in these areas may signal an arteriovenous malformation, most notably a vein of Galen malformation, which often presents with heart failure and can be rapidly fatal without recognition. In tachypnic or tachycardic infants, maintain a systematic approach despite rapid respiratory and cardiac cycles. Distinguish physiologic changes such as variable splitting of the second heart sound from pathologic findings. Listen through multiple cycles to avoid mistaking transmitted breath sounds for murmurs. Careful, ordered auscultation reduces the risk of missing clinically significant disease in unstable neonates. The first heart sound, S1, occurs with closure of the mitral and tricuspid valves. This marks the onset of ventricular systole. In neonates, it should be a single, crisp sound. Splitting of S1 is uncommon and generally pathologic when present. The second heart sound, S2, reflects closure of the aortic and pulmonic valves. In term and preterm infants, physiologic splitting is expected. During inspiration, increased venous return to the right heart delays pulmonic closure, widening the split. During expiration, reduced right-sided filling shortens right ventricular ejection time, narrowing the interval between aortic and pulmonic closure. The split should be symmetric and vary with respiration. A fixed or widely split S2 raises suspicion for atrial septal defect or other pathology. In practice, auscultation requires patience. Neonatal heart rates are rapid, making subtle changes easy to miss. Listening carefully over multiple cycles helps distinguish true splitting from artifact, recognition of normal S1 and physiologic S2. Splitting is critical, since abnormal intensity or timing often provides the first clue to congenital heart disease. Physiologic splitting of the second heart sound is a reassuring finding in neonates. It nearly always indicates structurally normal cardiac anatomy. A single unsplit S2 should raise concern for pathology, such as truncus arteriosus, pulmonary atresia, or severe aortic stenosis. Additional abnormal sounds provide further diagnostic clues. An S3 gallop in neonates reflects rapid ventricular filling in the setting of volume overload or heart failure. It is often heard in conditions like significant left-to-right shunts or dilated cardiomyopathy. An S4 gallop indicates decreased ventricular compliance, frequently associated with hypertrophic or restrictive cardiomyopathy, though less common in this age group. Clicks are equally important. Ejection clicks accompany semilunar valve stenosis, such as critical aortic stenosis, and are typically heard shortly after S1. They reflect abrupt halting of stiff valve leaflets during systolic opening. Recognition of these findings during auscultation provides early evidence of significant structural disease, guiding timely echocardiography and intervention. Murmur assessment in neonates requires correlating the auscultation site with sound characteristics. At the right upper sternal border, a harsh systolic murmur is most often associated with narrowing of the aortic valve. The left upper sternal border is the typical location for murmurs from pulmonic valve obstruction, which can intensify as pulmonary vascular resistance falls. Murmurs at the left lower sternal border frequently arise from ventricular septal defects or tricuspid regurgitation. At the apex, abnormal findings often reflect mitral valve lesions. Grading intensity with the Levine scale is essential for clinical interpretation. A grade 1 murmur is faint and requires concentration to detect, while grade 2 is soft but readily audible. Grade 3 is moderately loud without a thrill. A palpable thrill places the murmur at grade 4 or higher. Grade 5 is heard with the stethoscope barely touching the chest, and grade 6 is audible even when the stethoscope is slightly lifted away. Murmurs at grade 4 and above almost always signify significant pathology and should prompt further evaluation. Different cardiac lesions create murmurs with distinct qualities, locations, and radiation patterns that reflect the underlying hemodynamics. A ventricular septal defect produces a harsh pansystolic murmur at the left lower sternal border. The sound persists across all of systole because the pressure gradient between left and right ventricles is constant throughout contraction. Patent ductus arteriosus creates a continuous machinery murmur, often radiating to the back. This arises because blood flows from aorta to pulmonary artery in both systole and diastole, driven by persistent pressure difference between the two vessels. Aortic stenosis generates a harsh systolic ejection murmur radiating to the neck or carotids. The radiation occurs as turbulent jet flow from the narrowed aortic valve is transmitted into the ascending aorta and up toward the great vessels. Pulmonic stenosis produces a systolic ejection murmur radiating to the back or axilla. The turbulence through a narrowed right ventricular outflow tract transmits along the pulmonary arteries into posterior thoracic regions. In truncus arteriosus, a single arterial trunk arises, producing a harsh systolic murmur. The second heart sound is single because only one semilunar valve is closing, not the normal two. Valvular stenosis, whether aortic or pulmonic, often adds a sharp ejection click. This sound occurs when stiff semilunar valve leaflets abruptly halt as they attempt to open under systolic pressure. Each murmur reflects specific changes in blood flow, pressure gradients, or valve motion. Recognizing these acoustic patterns allows clinicians to connect what is heard at the bedside with the underlying pathophysiology. Electrocardiographic parameters in neonates differ from those in older children because of transitional circulation and right heart dominance. Normal heart rate is higher in this age group, typically 120 to 160 beats per minute when awake and 80 to 120 during sleep. Sinus rates above 180 are generally physiologic, but exceeding 220 suggests pathologic tachycardia such as supraventricular tachycardia. The PR interval is shorter because conduction tissue is relatively small and compact. Values usually range from 80 to 160 milliseconds depending on age and heart rate. Prolongation may indicate first-degree heart block. QRS duration should be less than 80 milliseconds in newborns. Wider complexes raise concern for ventricular conduction abnormalities or ectopic rhythms. The corrected QT interval is normally less than 450 milliseconds. Intervals between 450 and 500 require caution and follow-up, while values above 500 are always considered abnormal and may signal long QT syndrome. Finally, axis deviation is expected. Newborns often show a rightward axis because of physiologic right ventricular dominance in utero. With growth and falling pulmonary vascular resistance, the axis shifts toward the left over the first months of life. Arrhythmias in neonates are broadly divided into bradyarrhythmias and tachyarrhythmias, and the distinction matters because the mechanisms and implications are very different. Sinus bradycardia in newborns is defined as a rate that falls below what is appropriate for age and physiologic state. During sleep or with vagal stimulation, brief dips may be normal, but persistent bradycardia outside those contexts usually indicates pathology. Common triggers include increased vagal tone from suctioning, reflux, apnea, or intracranial pressure. The critical point is that the rhythm still originates from the sinus node. Heart block occurs when conduction between atria and ventricles is impaired. First-degree block shows up as a prolonged PR interval, second degree involves intermittent failure of conduction, and complete block represents total dissociation between atrial and ventricular activity. Congenital complete block is often associated with maternal autoimmune disease. Neonates may tolerate rates as low as 50 to 60 beats per minute if ventricular function is preserved. On the tachyarrhythmia side, sinus tachycardia is usually a normal physiologic response to stressors such as fever, anemia, pain, or infection. Rates up to 180 beats per minute can be normal. Variability and appropriate P-wave morphology confirm sinus origin. Supraventricular tachycardia is the most common pathologic tachyarrhythmia in this age group. It is typically due to a reentrant circuit, often involving an accessory pathway. Unlike sinus tachycardia, SVT presents as a very rapid, regular rhythm, often exceeding 220 beats per minute, with abrupt onset and termination. Sustained episodes can compromise cardiac output and lead to heart failure if not recognized. Bradycardia in the neonatal intensive care environment is defined as a heart rate less than 80 beats per minute, distinct from the resuscitation threshold of 100. This lower rate often reflects the predominance of parasympathetic tone in the newborn, particularly during sleep or feeding when vagal stimulation is accentuated. The sympathetic system is still maturing, so transient slowing is not unusual. The essential consideration is whether the bradycardia represents a normal physiologic pattern or a pathologic process requiring further evaluation. Non-cardiac conditions account for most neonatal bradycardia episodes. Hypoxia from lung disease or apnea of prematurity is a frequent and correctable cause, with bradycardia serving as a marker of inadequate oxygen delivery. Hypoglycemia and disturbances in potassium, calcium, or sodium interfere with myocardial excitability and conduction, suppressing the heart rate. Congenital hypothyroidism decreases metabolic drive and reduces chronotropic responsiveness. Neurologic processes, including intracranial hypertension or therapeutic hypothermia for hypoxic ischemic encephalopathy, also reduce rate by blunting autonomic output. Finally, medications such as maternal beta blockers, antiarrhythmics, or magnesium sulfate cross the placenta or persist after delivery, directly slowing conduction. Each of these factors must be considered and corrected before assuming primary cardiac disease. Cardiac causes, though less frequent, carry significant implications. Sinus node dysfunction may reflect immaturity in very preterm infants, but intrinsic disease must be considered if the pattern persists. Atrioventricular block, ranging from first-degree delay to second-degree Mobitz 2 or complete block, is often immune-mediated through maternal antibodies and may be irreversible. Channelopathies such as congenital long QT can first manifest as neonatal bradycardia, with prolonged repolarization intervals creating risk for torsades de pointe and sudden collapse. Myocarditis and structural congenital heart disease interfere with conduction pathways or myocardial function, while surgical or catheter-based interventions may damage conduction tissue. Recognizing these cardiac causes is critical, as they frequently dictate long-term surveillance or pacing strategies. Evaluation begins with rhythm confirmation, because what appears as bradycardia on the monitor may be artifact from movement or lead displacement. Auscultation provides the true rate, while a bedside ECG confirms rhythm origin. This step prevents unnecessary interventions for false alarms. Airway and ventilation assessment comes next, as hypoventilation and apnea are the most common precipitants of bradycardia in neonates. In primary apnea, often vagally mediated or due to brief immaturity of respiratory drive, the infant responds to gentle tactile stimulation or simple airway repositioning. If bradycardia accompanies secondary apnea, where respiratory effort is absent, the event reflects oxygen deprivation severe enough to suppress both respiratory and cardiac drive. In this setting, positive pressure ventilation, or CPAP, is essential to restore oxygen delivery and reverse the bradycardia. Optimizing oxygenation is critical. Newborns are particularly sensitive to hypoxemia because their myocardium has limited anaerobic reserve. Suctioning the airway clears secretions that obstruct airflow, while adjusting inspired oxygen and continuously monitoring saturations ensures effective delivery. Even modest hypoxemia can rapidly depress sinus node activity and AV conduction. Circulatory assessment provides clues to underlying disease. Capillary refill and extremity warmth reflect systemic perfusion. Peripheral pulses and blood pressure trends may uncover low cardiac output or shock physiology. Hepatomegaly suggests right heart strain or volume overload, and the presence of murmurs may reveal structural heart disease. This integrated exam establishes whether the bradycardia is a transient vagal event or a marker of broader cardiovascular compromise. Once immediate stabilization is underway, the evaluation extends to systemic contributors. Laboratory studies, glucose, electrolytes, blood gas, thyroid tests, and infection screening identify common reversible causes. Medication review is essential, as maternal beta blockers, magnesium, sedatives, and antiarrhythmics can suppress neonatal heart rate. Feeding or procedural events may trigger vagal bradycardia, resolving once the stimulus is removed. Cardiac investigations include a 12-lead ECG for rhythm and interval analysis, continuous monitoring for recurrent events, and echocardiography when structural disease is suspected. Escalation depends on etiology. Caffeine is effective for apnea of prematurity. Persistent conduction disease or prolonged QTC requires cardiology involvement. Symptomatic or unstable bradycardia, despite correction of reversible factors, may necessitate temporary or permanent pacing. Supraventricular tachycardia in neonates has a characteristic profile that sets it apart from physiologic sinus tachycardia. Rates usually exceed 220 beats per minute, and in many infants can approach 300. This is important because sinus node-driven rhythms almost never sustain at that level. Exceeding the expected physiologic maximum should immediately raise suspicion for SVT. Another defining feature is the absence of variability. Sinus tachycardia changes with activity, agitation, or sleep, whereas SVT maintains a fixed, rapid rhythm. On electrocardiogram, the QRS complexes are narrow, unless conduction through the bundle branches is aberrant, which can make SVT appear wide complex and mimic ventricular tachycardia. SVT is the most common sustained arrhythmia in the neonatal period. The mechanism is almost always reentry. In infants, this usually involves an accessory pathway that bypasses the atrioventricular node, classically Wolff-Parkinson-White syndrome, or less commonly, atrioventricular nodal reentry. Clinically, infants may tolerate these rapid rates for hours to days, but prolonged episodes can impair ventricular function and precipitate heart failure. Recognizing the distinctive features, rate greater than 220, narrow complexes, and fixed rhythm is critical for timely intervention. Management of supraventricular tachycardia in neonates follows a stepwise progression from least invasive to most invasive because the goal is always to restore rhythm safely while minimizing risk. The first step is vagal stimulation. which takes advantage of the infant's strong parasympathetic reflexes. Maneuvers such as applying ice to the face trigger the diving reflex, slowing conduction through the atrioventricular node. This can interrupt the reentry circuit without medication or shocks. These methods are attempted first because they are safe, rapidly reversible, and can be performed immediately at the bedside. If vagal maneuvers fail, or if the rhythm recurs, intravenous adenosine is the next choice. Adenosine transiently blocks conduction through the atrioventricular node, which usually terminates reentrant tachycardia. It must be delivered as a rapid push, followed by a flush to ensure the drug reaches the heart before being metabolized. Dosing begins at 0.1 milligram per kilogram, increasing to 0.2 if the first dose fails. Adenosine is preferred over older agents such as digoxin because of its short half-life and high effectiveness. For infants who are unstable, showing hypotension, poor perfusion, or depressed consciousness, immediate synchronized cardioversion is indicated. In this situation, waiting for less invasive measures risks circulatory collapse, so escalation is justified. After stabilization, maintenance therapy may be required to prevent recurrence. Beta blockers such as propranolol are commonly used, with flecainide or other antiarrhythmics reserved for refractory cases. Digoxin may still have a role in some infants, although caution is required in those with Wolff-Parkinson-White syndrome because of the risk of precipitating dangerous rhythms. This structured progression, beginning with non-invasive reflex activation, moving to rapid-acting pharmacology, and then to electrical therapy, when instability is present, balances efficacy with safety while tailoring interventions to the infant's hemodynamic status. Premature beats occur when cardiac tissue outside the normal conduction pathway fires early. In the atria, this produces premature atrial contractions with abnormal P-wave morphology because the impulse originates from tissue other than the sinus node. In the ventricles, premature beats bypass the normal His-Purkinje system, generating a widened QRS complex. These early beats reflect increased automaticity or triggered activity, often transient in neonates as the conduction system matures. The reason they rarely require treatment is that conduction resumes normally, preserving overall cardiac output. Recognition matters because blocked packs can mimic bradycardia on a monitor, and frequent PVCs may suggest myocardial irritation or structural disease. Most cases resolve spontaneously as the conduction system stabilizes in the first months of life. Atrial ectopic tachycardia results from a focus of atrial tissue firing automatically at a faster rate than the sinus node. Because it is driven by abnormal automaticity, the onset is gradual rather than abrupt, producing the characteristic warm-up and cool-down pattern. This mechanism also explains why the P waves differ from sinus rhythm. They reflect activation from an ectopic origin with a different conduction axis. Sustained tachycardia prevents the ventricles from filling adequately, causing tachycardia-induced cardiomyopathy if unrecognized. The key clinical clue is a persistent fast rhythm that does not respond to vagal maneuvers, distinguishing it from reentrant supraventricular tachycardia. Therapy targets suppression of abnormal automaticity with beta blockers or antiarrhythmic drugs, while most neonatal cases resolve as the atrial tissue matures. Atrial flutter is caused by a reentrant circuit in the atrium, most often looping around the tricuspid annulus. The atrial rate can reach 300 to 600 beats per minute, but the atrioventricular node acts as a physiologic filter, typically allowing only every second or third impulse through. This explains why ventricular rates are usually half or a third of the atrial rate. On ECG, the sawtooth flutter waves reflect rapid, organized atrial depolarization without a return to baseline. The clinical risk is that persistent atrial flutter can reduce cardiac output and cause high drops in utero or heart failure after birth. Cardioversion is preferred because drugs cannot reliably interrupt the reentry circuit. Recurrence is uncommon in otherwise healthy newborns, which is why long-term therapy is usually not required unless there is underlying structural disease or atrial dilation. First-degree AV block is characterized by a prolonged PR interval. In most neonates, it is asymptomatic and may even resolve spontaneously, but it can signal early conduction disease in the setting of maternal autoantibodies. Second-degree block is divided into two forms. Mobitz type I, or Wenckebach, shows progressive lengthening of the PR interval until a QRS is dropped. This pattern can sometimes improve or remain stable. Mobitz type 2 involves sudden, unpredictable failure of conduction after a fixed PR interval, and it carries a higher risk of progressing to complete heart block. In neonates, these conduction delays are most often seen in the setting of maternal SSA/SSB antibodies. They reflect early stages of immune-mediated damage to the atrioventricular node and conduction tissue. Many cases are transient, but some will progress to third-degree block, which requires its own focused discussion. Third degree, or complete heart block, is defined by complete atrioventricular dissociation. Atrial impulses fail to reach the ventricles, which are paced only by a slower escape rhythm. This rhythm is often too slow to maintain normal cardiac output in newborns. In neonates, the most common cause is autoimmune injury from maternal anti-SA and anti-SSB antibodies, the hallmark of neonatal lupus. These antibodies cross the placenta, bind to fetal cardiomyocytes, and trigger inflammation, apoptosis, and fibrosis in the conduction system. This process is irreversible and accounts for more than 80% of congenital complete heart block in structurally normal hearts. Less common causes include post-surgical injury, myocarditis, or underlying congenital heart disease. Clinically, infants may present with profound bradycardia, poor perfusion, or signs of heart failure. When severe, it can cause hydrops and even fetal demise in utero. Some infants are stable immediately after birth, but many deteriorate. Management depends on stability. Asymptomatic infants may be observed closely, but persistent bradycardia with hemodynamic compromise requires pacing support, and up to 60% will ultimately need a pacemaker. In utero, maternal treatment with fluorinated steroids, intravenous immunoglobulin, or hydroxychloroquine may stabilize progression from second to third degree block, but once complete block is established, reversal is unlikely. Ventricular tachycardia originates from an ectopic ventricular focus or reentry circuit within diseased myocardium. Because the impulse does not use the His-Purkinje system, the QRS complex is wide. Capture and fusion beats occur when occasional sinus impulses conduct through, revealing the underlying atrial ventricular dissociation. The danger is that sustained ventricular tachycardia severely reduces stroke volume and may degenerate into ventricular fibrillation. Causes in neonates include myocarditis, cardiomyopathies, congenital channelopathies such as long QT syndrome, or surgical scarring. The clinical challenge is distinguishing ventricular tachycardia from supraventricular tachycardia with bundle branch block, as treatment differs. Hemodynamically unstable infants require immediate synchronized cardioversion because the arrhythmia prevents adequate perfusion. Stable infants may be managed with antiarrhythmic therapy, but evaluation for underlying pathology is essential to prevent recurrence. Axis assessment on the neonatal ECG provides key diagnostic clues because it reflects which ventricle is dominating conduction. In the normal newborn, the axis is rightward. This is expected because the fetal circulation maintains high pulmonary pressures, keeping the right ventricle thick-walled and dominant at birth. Over the first weeks to months, the axis gradually shifts leftward as pulmonary vascular resistance falls and the left ventricle takes over systemic output. Left axis deviation in a neonate is not normal and should raise concern for congenital lesions that impair right-sided conduction or flow. Classic associations include tricuspid atresia and complete atrioventricular canal defects. In tricuspid atresia, absence of effective right ventricular inflow shifts depolarization vectors leftward. An extreme right axis, more rightward than the physiologic range, often indicates severe right heart disease. Conditions such as pulmonary atresia with intact ventricular septum or Epstein anomaly produce a disproportionately enlarged or dysfunctional right atrium and ventricle, driving conduction further rightward. Axis deviation reflects the balance of ventricular forces and the structural condition of the heart. Identifying whether the axis is expected, exaggerated, or reversed allows clinicians to connect the ECG pattern with likely congenital lesions in the neonatal period. Electrolyte abnormalities profoundly alter myocardial conduction, and the ECG often provides the earliest warning. With hyperkalemia, the first sign is tall, narrow, peaked T waves. As potassium rises, conduction slows, producing widening of the QRS complex. If uncorrected, the QRS and T wave merge into a sine wave pattern, which represents impending ventricular arrest. These progressive changes occur because excess extracellular potassium reduces the resting membrane potential, slowing depolarization and conduction through the myocardium. Hypokalemia has the opposite effect, prolonging repolarization. ECG findings include flattened T waves, appearance of prominent U waves, and prolongation of the QT interval. These changes reflect delayed ventricular repolarization and increased susceptibility to arrhythmias, such as torsades de Puentes. Both conditions are high risk in neonates because even modest electrolyte shifts can destabilize conduction in immature myocardium. Prompt recognition of these ECG patterns enables rapid correction before progression to life-threatening arrhythmias. Calcium disturbances leave distinct fingerprints on the neonatal ECG. Hypercalcemia shortens ventricular repolarization, which shows up as a shortened QT interval. In more severe cases, prominent J waves, also called Osborn waves, may appear at the junction of the QRS and ST segment. These changes occur because elevated calcium accelerates phase 2 of the action potential, reducing the time the ventricles remain depolarized. Hypocalcemia produces the opposite effect by prolonging ventricular repolarization. The QT interval lengthens, and T-wave morphology may become abnormal, sometimes flattened or inverted. This delayed repolarization increases susceptibility to ventricular arrhythmias, particularly torsades de Puentes. Because QT interval changes are not specific to calcium alone, correlation with serum levels and clinical findings is essential. For example, prolonged QT in a neonate might reflect hypocalcemia, but hypokalemia medications or congenital long QT syndrome can create the same pattern. Careful integration of ECG changes with laboratory and clinical context is therefore required to determine whether calcium is the driver. Electrocardiographic patterns in congenital heart disease reflect the chamber that is carrying the dominant workload. In tricuspid atresia, the right ventricle is severely underdeveloped, leaving the left ventricle responsible for systemic output. This shifts the axis leftward and produces signs of left ventricular hypertrophy on ECG. Tetralogy of Fallot combines right ventricular outflow obstruction with a large ventricular septal defect. The right ventricle hypertrophies as it pumps against obstruction, so the ECG shows right axis deviation and right ventricular hypertrophy. In transposition of the great arteries, the right ventricle supports systemic circulation. As a result, right ventricular hypertrophy is present, often with a normal or rightward axis. Hypoplastic left heart syndrome leaves the right ventricle as the systemic pump. The ECG shows right ventricular hypertrophy with minimal or absent left-sided forces. In cortation of the aorta, resistance to outflow from the left ventricle leads to hypertrophy if obstruction is significant. ECG evidence of left ventricular hypertrophy becomes more apparent with severe or long-standing narrowing. ECG changes in these conditions highlight which ventricle is under strain and provide early clues about the type of structural lesion. While echocardiography remains the definitive test, axis shifts and hypertrophy patterns on the ECG can guide initial bedside interpretation in unstable neonates.